Hello everyone, today I'll be taking another VivaLive session with QQSphere on the subject of biochemistry under the topic clinical biochemistry with the subtopic of diabetes mellitus. So let's start.
Welcome to the examination. We will be focusing on clinical biochemistry, particularly metabolic disorders. Let's start with diabetes mellitus. Can you tell me the primary biochemical alterations you would expect to see in a patient presenting with type 1 diabetes?
In a patient of type 1 diabetes, which is also called absolute insulin deficiency, there occurs autoimmune destruction of pancreatic beta cells, leading to an inability to produce insulin. The cells cannot utilize glucose, causing increased hepatic glucose output, hyperglycemia, and lipolysis.
That's correct. Given the increased lipolysis you mentioned, what biochemical findings would you expect to observe in the laboratory diagnosis of ketoacidosis, which is a common complication? Think about blood levels of specific substances.
In case of ketoacidosis, uh, we will have uh, accelerated lipolysis, high ketones, acid base status will be of low pH and high anion gap. Blood glucose will be increased. There will be in less osmolarity and symptoms of nausea, vomiting, and abdominal pain.
You are mostly correct, but could you clarify what you mean by less osmolarity? Typically, with significant hyperglycemia, what would you expect to happen to plasma osmolarity? Also, regarding ketones, which specific ketone bodies would be present in elevated amounts?
In case of diabetic ketoacidosis, the osmolarity will be less than 320 milliosmoles per kg. But in case of hyperosmolar hyperglycemic state, the osmolarity will be very high, more than 350 milliosmoles per kg.
That's correct about the difference from HHS. However, in DKA, osmolarity can be normal or elevated, not necessarily low. Now, back to my question. Which specific ketone bodies are we primarily concerned with in ketoacidosis?
In case of ketoacidosis, the ketones found in the body are beta hydroxybutyrate or acetoacetate or acetones.
Excellent. You've identified the correct ketone bodies. Now, how do these ketone bodies impact the blood's pH, and what is the metabolic basis of the high anion gap you mentioned earlier?
These ketones make the blood pH more acidic, and the high anion gap metabolic acidosis represents a mixed acid base disorder where a high anion gap metabolic acidosis or HAGMA is masked or accompanied by metabolic alkalosis.
While it's true that the keto acids lower the pH, the high anion gap in DKA is primarily due to the accumulation of unmeasured anions like beta hydroxybutyrate and acetoacetate, not necessarily a mixed disorder with alkalosis. Now, moving on, how would you monitor the effectiveness of treatment for a patient with DKA using laboratory tests? What parameters would you follow?
We will perform uh, blood
Blood
gas
glucose is
analysis.
one parameter, yes. What other biochemical markers would be crucial for monitoring? Think about what we discussed earlier regarding acid base status and electrolytes.
We will do blood gas analysis and serum ketones, blood pH, and anion gap will be monitored. And for electrolytes, we will do electrolyte panel, urine analysis for ketones and glucose in the urine, and additional tests like ECG might be done.
That's a comprehensive monitoring plan. You mentioned urine ketones. However, direct measurement of serum beta hydroxybutyrate is often preferred for monitoring the resolution of ketoacidosis, as it's the main ketone produced. Let's shift gears slightly. In contrast to type 1, what is the biochemical hallmark of dyslipidemia commonly seen in type 2 diabetes mellitus? Think about specific lipid types.
Um, I don't know the answer. Can you explain?
No problem. In type 2 diabetes, the typical pattern is elevated triglycerides, low levels of high density lipoprotein cholesterol, that's good cholesterol, and sometimes an increase in small, dense, low density lipoprotein particles. This combination is often called the lipid triad. So, based on that, what would replace normal monitoring tests, particularly for cardiovascular risk, when managing a patient with type 2 diabetes?